Hello, and welcome to the session on rural healthcare as part of the Iowa Ideas Conference. My name is Tony Lays. I'm the moderator. I am a reporter and editor for KFF Health News covering rural health issues. I'm based in Des Moines. I'm also the former longtime health reporter for the Des Moines Register. Today we have two panelists. Nick Moore is an emergency medicine physician at the University of Iowa Hospitals and director of the Rural Telehealth Research Center there. Steve Simonin is president and CEO of Iowa Specialty Hospitals and Clinics based in North Central Iowa. This will be an informal conversation. We would welcome questions sent in through the chat. They would be a great assistance to us in keeping it going. We're going to start. I'm going to ask you two guys to introduce yourselves and talk a little bit about what your role is in trying to improve healthcare for rural Iowans. Steve, why don't you go first?
Okay, my name is Steve Simonin. I'm president and CEO of Iowa Specialty Hospitals and Clinics. I've been here as CEO in my position for 27 years. I have two small hospitals in North Central Iowa, in Clarion and Belmont, both critical access hospitals. When I came here in 1996, I was on the panel to bring critical access to Iowa. So these two hospitals represented two out of the three first critical access hospitals in Iowa. So I've been involved with that since January 1 of 2000. How have I impacted and changed? I think we've done a lot of innovative things within our hospital. We've grown significantly. We do a lot of OB here at the hospital. We do a lot of orthopedics. We do a lot of different things like bariatric surgery. Our patients come from all over Iowa. I think we demonstrate thinking outside of the box. I've been on the board for Iowa Rural Health Association for a long time. More, Tony?
No, that'll do. Nick, tell us a little bit about your center and what you're aiming to do there.
Yeah, thanks, Tony. I'm Nick Moore at the University of Iowa. I've been here for about 12 years. And our focus has been to conduct research that's policy relevant to try to understand how we can improve healthcare for people in rural areas, not just in rural Iowa. We have Rural Telehealth Research Center here, which is a collaborative center between the University of Iowa, the University of Southern Maine, and the University of North Carolina. And through that center, we conduct research projects to understand how telehealth is being used to improve the health of people in rural communities. Our focus has been primarily on acute care, emergency care, critical care, but we've also had a focus in mental health and in opioid use disorder and in school-based health and other areas where telehealth innovation is really happening. We partner with telehealth providers in Iowa and really throughout the country to conduct evaluations and understand really what telehealth at scale looks like. We've had our center here since 2015, but as we all know, telehealth really kind of had a rapid expansion during the time of the COVID-19 public health emergency. And so a lot of our work since that time has been trying to understand how this expansion of telehealth has influenced rural health more broadly.
Thanks. And what do you see as the areas where telehealth is helping the most? And what do you see as areas where it still faces some real challenges or doesn't help folks as much?
Yeah, it's a really good question. I think a lot of what we saw in terms of expansion during the public health emergency wasn't necessarily just in rural areas, right? It was more broadly than just that. But I think that, we see in health policy right now that in terms of payment policy, it's been expanded most in mental health and behavioral health. I think that with the shortage of school nurses, there's been some really creative and innovative programs to be able to provide healthcare within schools in places that don't have a school nurse, which I think is innovative. We've worked with partners who are providing telehealth now as a crisis response with law enforcement to provide healthcare in a place where traditionally that's not happened. So those are all small demonstration projects that I think are really interesting. But I think that when we think about healthcare more broadly, telehealth is most effective for conditions where an in-person visit isn't necessary. And so behavioral health, mental health, increasingly opioid use disorder, increasingly other kinds of psychotherapy has been really an effective place where this has been done. The other group of telehealth interventions has really focused on direct-to-consumer telehealth, integrated typically into primary care. And that is maybe not a place where all of the healthcare is provided by telehealth, but some of the healthcare can be provided in that way. That also often has to do with telemonitoring. So for people who have chronic medical conditions and they at home can collect biometric data or device-related data without having to go to a clinic. Really a leader in this space has been the VA. The Veterans Health Administration was an early adopter of telehealth, and because of the structure of the VA health system, I think that was something that they invested in early and have had a lot of innovation in that area, but really a lot of commitment in terms of resources as well.
Steve, how do you see it affecting your hospitals and clinics, telehealth?
Telehealth, like Nick was saying, definitely in mental health. We have most of our mental health visits are being done via telehealth. Our bariatric service out of Des Moines, we're doing a lot of telehealth on that. We're definitely not seeing a lot of telehealth in our OB or orthopedics, lots of hands-on stuff. So, we did that originally with COVID, but we scaled back a lot on our telehealth in those areas.
How come? How come you're scaling back?
We scale back on obviously on the ortho and the OB. I mean, you definitely see them in person. Yeah, the payment parity on the mental health made it so easy for patients. Plus, they didn't have to drive in. Just the whole element of having to come in and wait in the waiting room and everything else. It's just really easy for our mental health population.
And where's the payment parity on that now? And going forward?
With mental health, Nick, correct me if I'm wrong, but didn't they brought mental health payment parity on telehealth, but not on all the other services? Is that right?
So for Medicare payment only, right? The COVID-19 public health emergency expansion lasts through the end of 2024, but for mental health, it's been extended beyond that permanently. So there's some qualifications around that, but for Medicare patients, that's true. Mm-hmm.
So for the patients going forward, you can expect mental health to continue to be available by telehealth, but maybe not quite so many other services?
I would expect that we're going to see that this is the new way that mental health care is provided. I have a neighbor who's a psychiatrist, and she is a psychiatrist for a clinic in Montana from her basement and has done this for a number of years now because of the shortage of mental health professionals nationally. So I don't think that it's certainly something that expanded around the public health emergency, but I think one of the things that we've learned is that it's really effective, right? We're talking about scheduled mental health services, but there's also on-demand mental health services. We have almost 120 hospitals in Iowa. We don't have enough psychiatrists to be able to see people who are having mental health crises in all of those places. And a lot of rural hospitals in Iowa now are using services to conduct mental health evaluations, safety screening, maybe mental health admissions, evaluating these patients for the need for acute care services in emergency departments by telehealth. So I think that this has become not really an alternative model, but the primary model really in a lot of places. And I don't really see that being reversed anytime soon.
Steve, how much does it help? I think a lot of the focus in the public with telehealth is when the patients are using it. How much does it help that a provider in a small town hospital or clinic can use telehealth to consult with a specialist in a big city? How much are you doing that, and do you expect that to continue?
Well, Nick, you were just talking about the psychiatrist
right.
in the ER. that's been a huge saver for us. It's been a huge benefit in our rural ERs. I've got a couple of them, and that's been a lifesaver for our services. Just not having to call around and find beds and try and desperately just seek care. Our providers love that service. So and from a telehealth perspective, I mean the whole radiology after hours, I would assume that's kind of the same thing, right, Nick? As far as being able to check with back and forth, yeah, it's been around for a while, and I think it's well used by the staff.
And does that help small hospitals keep services going, that you have that backup?
Yeah, definitely.
I want to switch a little bit to staffing in general. So many of the stories that I write about rural healthcare come down to, we'd love to have this new service, but there's just not enough staff. How significant is the staffing issue? How much of it is temporary related to the COVID crisis? And where do you think we're going with it? What do you hope to see to help you deal with it, Steve?
I think the rise in agency and agency nursing and agency lab and agency, just went crazy. And in the market, I mean, we were paying double, triple, quadruple rates, and it just it hurt us financially. And those rates have come back down to kind of pre-COVID levels right now for agency nurses, but we're just finding the whole kind of staffing model flipped, where we used to be able to bring in staff and things. It's just the whole supply demand thing has changed completely. Now we're seeing it right now from an anesthesia perspective. And I was talking to someone yesterday with regards to CRNA, certified registered nurse anesthetist, and Iowa is seeing a huge inflation in our costs on that. So we're having a hard time right now, just even staffing our ORs and things in the rural area because of availability of CRNAs.
We were talking last week about the nursing home situation with staffing. The hospitals aren't in quite as much of a pinch as the nursing homes. Is that right? Do you think?
Not as much. We get reimbursed differently at the hospitals for skilled care or nursing home higher level care, and so we probably don't have the same issues as a lot of the nursing homes. Because Tony, you were talking about stories about nursing homes around Iowa closing and just having a hard time getting staff, and they're having to deal with the same cost for nursing that we are. But a lot of times the rural hospitals or the hospitals in general have a higher budget and have a higher ability to pay. But yeah, so it's got to be tough for the nursing homes.
But on the hospitals, Iowa has been relatively fortunate. We've only had one hospital closed in the last 20 years or so. The Keokuk Hospital is the only one. Some other states have seen a lot more closures. Why do you think that is, and do you expect that to continue, Steve? That we're going to be spared seeing a whole bunch of hospitals close in rural areas?
Okay, so with the advent or bringing on critical access back in 2000 was great. When Medicaid followed the example on paying cost reimbursement back in 2003 or 2004, that was fantastic. It was great for rural hospitals. In 2016, Medicaid brought in managed care. Our reimbursements started dropping. We're starting to see a lot more financial concerns within the rural hospitals. I don't know. Over the next couple of years, we might be seeing some more rural hospital closure in Iowa, because the rural hospitals that I know of are seeing some negative margins. I don't, but we're expecting some good financial um, news from doing some different things with Medicaid. That's kind of complicated, isn't it?
Okay, yeah, we won't get
Um,
deep into that. Let's talk a little bit about this new rural emergency hospital model that the federal government just introduced within the last year. Um, Explain for lay people what a rural emergency hospital will be and how it's different, Steve.
okay. First of all, in the United States, there have been about 12 hospitals nationwide that have converted over the rural emergency hospital. Rural emergency hospital is basically a hospital that has an existing complete outpatient services, can do longer term skilled patients, and has an active emergency room. For that, you get payment on a monthly basis, a stipend, and then 105% of the Medicare fee schedule for outpatient services. So it's different from critical access, because a critical access hospital nationwide, there's 1,300 critical access hospitals in Iowa. 82 out of 117 hospitals are critical access. We are up to 25 beds. We get 99%, used to be 101% of our costs back from Medicare, which is a lifesaver for most of us. So the difference between a critical access hospital and an REH hospital is, right now we have, in a critical access hospital, we have inpatient beds, and we get 99% of our costs back. Plus we get a good rate for our skilled patients, our skilled beds. For an REH, you get 105% of Medicare outpatient plus a stipend on a monthly basis, but you get a lower reimbursement for skilled patient, and you don't have any acute beds. So right now, personally, I don't see that you're going to see a lot of critical access hospitals in Iowa go towards the REH. When it was originally proposed 5, 6, 7 years ago, we were looking at a reimbursement of about 120% of our costs from Medicare. That would have been great. You would have seen a lot of hospitals jump towards that. But as it went through legislation and things, it came down to just 105% of the Medicare outpatient prospective payment.
So some of these little hospitals in Iowa have an average inpatient census of 1 or 2 a night,
Or less.
or less, which seems on its face like that doesn't make much sense to continue to me, just as a layperson. But then during COVID, during the height of COVID, all of a sudden the big hospitals were all full, and they were telling those little hospitals, please hang on to all the patients you can, right? Did that did that change the calculus in people's minds about whether those beds were still needed, the inpatient beds in small towns?
Didn't mind, Nick, down at the University of Iowa, we continue to hear from the big hospitals. Yeah, we're at 100% census, we're at 105% census. People are in the hallways. So from a small hospital perspective, it feels like we should have some sort of backup of beds. We might be 1 or 2, average daily census, but that could swell to 10 to 15 if there's another crisis.
Nick, how are doctors and other staffers at the big hospitals, how would they feel if a lot of the small hospitals got rid of their inpatient beds altogether, which is what the REH model would do?
Yeah, I think that's a good question. I think that when we talk about critical access hospitals, not all critical access hospitals are created equally, right? There are some that run near that 25% capacity and have specialists and are able to provide more care, and there are others that really have very low volume. The reality is that any changes that happen in a hospital that has very, very low inpatient volume don't affect the system as much as those hospitals that have a lot more inpatient volume. What we're seeing nationally is that every academic medical center, every tertiary care hospital in the country is busting at the seams. Everybody's running at 90, 95% capacity. And that's not true of every community hospital in the country, right? Increasingly, there's more and more conditions that require specialty care or procedural care that can't be provided every place. And as that care has been more and more centralized, what you see is that we have some hospitals that are running at 30% capacity, and then in the university hospital, all the beds are full, and there are people waiting in the hallways, and people waiting in rural hospitals. Steve, you probably have people in your hospital that sometimes are just waiting for a transfer and waiting for a bed to be available someplace else, where you're providing care really just until that bed is available somewhere. I think that's even more acute in mental health in Iowa right now. We have this huge shortage in mental health capacity, and I think probably many of the emergency departments in the state have mental health patients who require inpatient care who are sitting and waiting for available capacity, maybe in other hospitals or in local mental health units. But capacity is a big problem. In Iowa right now, we have a lot of hospitals for 3 million people, and we have a lot of hospital beds, but the availability of services in those beds isn't uniform. Johnson County, Iowa, where the university is, has more ICU beds and more ICU doctors per capita than any county in America.
Oh, wow.
So it's a huge regional referral base, but it's providing those backup services to really a lot of hospitals.
Hey, Nick, one of the questions that we have, Tony, I hope you don't mind me asking a question. So one of the questions that we've had from a rural perspective is, of that 100% census or 99% census, are there patients that could be taken care of in the community areas or in the community hospitals?
Yeah, that's a good question. There are some places that have put in place back transfer programs. Not a lot of the payers have been real supportive of that, transferring patients back to rural hospitals. But there are places that have done this a little bit. The other thing that fills up hospitals is not having rehab capacity outside of tertiary care centers to be able to send people who need those kinds of services post-discharge. So I think that those are probably two of the things where we'll see maybe more movement in the next 5 to 7 years.
Is that, and you're talking about nursing homes, including nursing homes that you're not taking?
Including nursing homes, but it's sometimes it's even a higher level than just skilled nursing, right? It's more acute rehab or long-term acute care facilities that people would be waiting to go to.
Mm-hmm. There's been a big push in the last few years in Iowa to improve mental health services that aren't hospitalization, short of hospitalization, for that to make it not so much a choice anymore that you either have to go to the hospital or there's nothing else. Has that been helping, or do you expect it to help going forward, ease the crunch on the psych units in the hospitals? I mean, I've heard for years that there are people who get sent there who don't really need that high of a level of service, but if it's the only choice, that's where they go.
Yeah, I think that there's truth to that. I think that one of the things that many of these telehealth, mental health, acute evaluation programs are trying to do is better identify which patients actually need inpatient care. So there's an element of that, but the reality still is that every emergency department in Iowa has people waiting for inpatient bed capacity who need inpatient care. So maybe not every hospital every day, but this is not a rare thing. It's even more true for children. And I think that it is an area in Iowa where we have some real opportunities to provide better and more timely care.
And you don't feel like that's getting better? I mean, the state has really been focusing on that in the last 8 or 10 years to try to improve those that whole system.
Yeah, there's a long lead time, number one. And most of what I'm talking about is acute care. So I think that there have been some really big improvements in the availability of outpatient mental health care that might overall be changing the proportion of folks that need to be admitted to the hospital.
Another area that gets a lot of concern and attention is EMS. That the EMS system, especially in rural areas, is pretty fragile and frayed. Steve, what are you seeing now, and what do you think is going to be the future of EMS in Iowa?
About in Wright County, where I'm at, about 10 years ago, we were approached at the hospital asking to take over the EMS program from the city. And as we looked into it and brought everybody together, we have three different systems within Wright County. And the three systems came together, and we found that we had about a $500,000 loss in our volunteer EMS through the cities. And so what we did was we found that it wasn't an essential service. It wasn't classified. So our county went ahead and we classified EMS as an essential service. And we went to a vote for everybody in the county to fund the loss up to $500,000, and it passed in our county. We got that through the legislation in Iowa 3 or 4 years ago. We just had another vote because it sunsetted after about 5 years, and it was amazing. In our county, we had 92% of the people, which we felt was amazing, vote in favor of this tax, which is not usually something that people like to vote for. But we found that from an essential perspective, people recognize and realize that ambulance and ER services in the rural area are essential, and we need to do that. So we've been pushing that out throughout Iowa to the different rural communities. There is we see a lot of loss, financial loss in EMS throughout Iowa and the rural communities.
Is it feasible to continue to rely so much on volunteers especially in rural areas?
Nick, you're the expert on that. We don't have a choice.
Yeah.
There's 800 EMS services in Iowa, roughly. There's about 9,000 EMS providers in the state, and about 65% of them are volunteers. If you look at the last 20 years, the number of calls nationally has just increased dramatically. The use of EMS, much of which is appropriate, right? But the use of EMS has increased. And I think that many of these services that started really a long time ago and were able to provide volunteer services when there weren't all that many calls really get stretched a little bit as those call volumes start to go up. I think that there are financial models that make this tough. I think that there's some movement in federal legislation encouraging EMS services to have practices that keep people out of hospitals where they can provide some care and release them and still have some kind of way for being paid for that care. Right now, the only way that an EMS service gets paid is if they take somebody to a hospital. So, if there's called out for somebody who fell or for somebody who has some other problem, they especially in volunteer services will be providing that. It's an important community service. But there has never been a financial model to support that work. So I think that what you're talking about in your county in terms of having a way for that to be increasingly tax supported is something that other communities are looking at, recognizing that this is a service that is necessary. But 85% of people who are providing that service in the state are doing so on a volunteer basis.
We got to the point.
Sorry, 65%.
We got to the point in Wright County where the city said, we don't have to go beyond our borders of the city to pick people up in the rural areas because we're not being reimbursed for that. This is a service that leaves a lot of the county, without emergency services. So we had to do this before we got to that point where it was just a city only.
So Nick, I want to.
The other thing that stretches these EMS agencies, to tell you the truth, we've talked about this increasing centralization of care. There are a lot of counties in Iowa who have an ambulance or maybe even 2 ambulances that are active at any time. But if there's somebody who shows up in the local hospital and needs to be taken to another community, to Iowa City or to Des Moines or someplace else, that ambulance can be out of service for really a period of time. And that influences the way that you try to set up EMS agencies. I think that things that used to be cared for in rural hospitals that aren't now really have taxed the EMS system probably more than we've talked about a whole lot.
Like what kind of cases?
Oh, I'm sorry.
What's that, Steve?
We also used to see for-profit transfer services that aren't around anymore because they're not getting reimbursed for that. So where we used to have the ability to call up someone to transfer our patient down to Iowa City, let's say, they don't exist anymore for us.
And if it's a psych patient, it's often a sheriff's deputy has to do it, right? And there might only be one or two sheriff's deputies on duty at a given time in a rural county. Nick, I want to go back to something you alluded to, which is there are some models where the EMS people, you would hire a professional EMS person, and then you could have them do some home health care, right? When they're not, or something like that, when they're not on a call, so they could get payment.
There are models. Yeah, there are models. They're called community paramedicine models, and these have mostly been grant funded up to this point, and mostly in more urban areas. Although there are some examples where this has been done in rural America too. But it really is combining services to be able to provide care that really is hard to provide now. So community paramedicine, an example of this might be an EMS agency that has a list of patients that they're going to go check on during the day. And, maybe it's because they were discharged from the hospital recently and they need to go and kind of see how their blood sugar is or what the symptoms of their heart failure are like. And in most of these programs, the goal here is to prevent readmissions so that people don't have to come back to a hospital. The idea is that most of those patients aren't going to need to be transferred. There's not a standard way that care can be billed right now, although there have been some really innovative partnerships with individual payers that has facilitated that, and I mentioned some grant funding. So community paramedicine is something that I think is growing, but there is more potential, and the barriers right now are primarily policy barriers. But as people get more experience with this, expect that we'll have a little better idea what role community paramedicine can play in decreasing overall costs of care. And once that is more clear, then some of those policy barriers are a little easier to address.
I mean, it sounds on its face like it makes a lot of sense. In other words, you don't have a paramedic sitting at the fire station 2/3 of the time waiting for a call. Like in between, they could be doing something and helping people. You've got that skill, and then also getting payment for the agency during that time. The question comes down to then who pays for it, right? But it's interesting. I also, there are a few pilot programs around the country where well, first of all, being an EMT these days is more complicated than it used to be, right? Because there's a lot more things that can be done for you in an ambulance than used to be. There's a lot more equipment to know how to run. There's a lot more things that can be done than just back in the old days where they would pick people up and get them to the hospital as soon as they could, and that was pretty much it. I'm exaggerating a little, but it's a more complicated thing, right? And so there are some pilot programs where there is telemedicine in the ambulance, where in a rural ambulance, where an ER doctor can watch what's happening in the ambulance and help advise the crew while they're bringing the patient in. How widespread is that, Nick? And what do you see as the potential for that kind of thing?
Yeah, it's a good question. I think we're still pretty early in the evolution of that. Mobile stroke units is probably where this sort of was most pronounced early on, and some of this was done in Europe, and some of it was done on the East Coast. Now there are some, I think, really compelling demonstration projects where this is being done more broadly in rural areas. There are things that make that hard. There are things that make that could be valuable in that, but I don't know that we really know necessarily how important that's going. We haven't seen the large scale of mature networks that we have in some other telehealth interventions, but if we can figure out how to use it well, I think that could make a lot of sense.
Nick, when I heard you talk last week, I ran to the ER and I talked to one of my docs and I said, how helpful would this be? And he said, at the scene of an accident, whether they come to our ER or go to a larger trauma center, and the decision has to be made by the scene, by the staff at the scene, to have eyes on by the doc would be very helpful in making those decisions. So they were excited about it when I talked to them.
Yeah, we're involved with a big stroke project right now because one of the things with acute stroke is that people who have uh, with smaller strokes can be treated with a medicine, a clot busting drug, but people who have really, really big strokes oftentimes need surgery. They need to have that clot removed. And it's really, really important. There aren't very many places that can provide that surgery, but it's really important that we identify who those people are so that they can get to a place that can perform that procedure, because it's really time sensitive. And so that's a place where telehealth, I think, has potentially a really important role to play, because identifying the people who are most likely to benefit from stopping at the local hospital for that clot busting drug, and also identifying the people where that isn't going to be enough and getting them to the place where they can have surgery fastest is really important.
And maybe calling out a helicopter.
Yeah.
I mean, they've been doing that with heart attack folks for a while, right? There's an EKG in the ambulance that a doctor can monitor at the hospital.
Mm-hmm. Yeah, yeah, that's a little bit simpler than the stroke problem,
Right.
because the paramedics evaluate the EKG and they make a decision on whether this is somebody who needs to be at a place that has a cath lab that can reopen that artery. The pre-hospital tools we have in stroke aren't as good as they are for cardiac care, so there's a little bit more uncertainty and it requires a little bit more expertise.
Um, we also had talked about the aging population, especially in rural areas. How much of a challenge is that? And especially going forward, you got the boomers now in their 60s and 70s, right? Getting older. How much is that going to be? Is that going to strain the rural healthcare system? And what can we do about it? But both the load of patients, but then also the availability of staff of the younger generations. Steve, what do you think? How worried are you about that?
Um, yeah, I don't know. We've always had an older population in our county. So it's something that we deal with all the time. You know, uh, um, I don't know. I haven't given it that much thought. I mean, it is what it is in the rural area. We have a older population. So
Are there other sources of workers that you think might be tapped? I mean, is there any support for loosening immigration restrictions for people who are willing to come work in healthcare, for example?
that yeah, that'd be great. You hear a lot of we haven't really used a lot of the international nursing. I
Mhm.
was talking to a big hospital a couple weeks ago, and they have a lot of international nursing students who come in, and it's been huge for them. So yeah, what we find in our area is just basically stepping down into the high schools and the junior highs, getting them interested in, and Tony, we talked a lot about scholarships last week and ways to get the local kids interested in and excited about getting into healthcare. And and so that's kind of how we feel that if we're going to have a long term staff, if they have roots in the community, that's by giving them scholarships and getting them interested in healthcare early, that's usually the best way it works for us.
And how has that been working?
Yeah, over 20 in my 27 years here, a lot of our docs, I met when they were in junior high here in Wright County.
Mhm.
My orthodox, I met him when he was 12.
Wow.
And so yeah, it's bringing them up from the community that it works well for us.
Are you seeing? I did a story a few months ago about how increasingly osteopathic physicians are taking the primary care jobs, especially in rural areas. That MDs tend to be going more to the cities and more to specialties that pay more. Are you seeing that in your area?
We've always had about 50-50 DOs and MDs.
Mhm.
It's just since I came, and we've always had a lot of DOs in the system. So
It's not changing.
not changing. I mean, it's just always been. We see a lot of our docs coming out of Des Moines, the Des Moines DMU, and it's just it's been a great source of staff for us.
And do you think patients notice the difference? Do they even know which one's which?
We don't advertise. We don't.
Oh yeah.
Out there. No, it's never been an issue.
And I've gone to both, and it's been good. But but you feel fortunate to have DMU, not quite in your backyard, but
yeah, no, it's fantastic.
That's great. You work on a little bit of an unusual model where you have a specialty service, the bariatric surgery, and you draw from Des Moines. Is that that kind of model help small hospitals have something, not just the basic service, but something you specialize in?
Yesterday, in kind of preparation for this, I wrote an article on for my newsletter, and I talked about how we're having to change our thoughts within the rural area as far as how do we provide services. Years and years ago, back in 2007, we brought on orthopedics. And for a small hospital, I mean, there's a lot of specialists who go out to rural hospitals, but we decided at that time back in 2007 to really focus on orthopedics. So we've got 5 orthopedic surgeons, a strong back program. We bring patients in from all around Iowa. Like I mentioned, we do a lot of obstetrics here, and we felt that if we're going to do it, we want to have a very deep program with OBGYNs, lots of family practice who also do OB. And then when we started working with the Belmont Hospital back in 2007, and we ended up building a new structure in 2012, we said we're going to have to focus more on just primary health. That's not going to be successful long term, or we thought. And so in 2014, we were able to bring on a bariatric program with a clinic down in Des Moines. And so about 60 to 70% of our patients are coming up from the Des Moines metro area to have bariatric surgery up in Belmont, which is hour and a half, hour 45 minutes away from the Des Moines metro, and the patients are coming up, and it's been successful. We've done thousands of bariatric sleeves over the years. Patients in Iowa will drive. We found it. I mean, I drive for a cup of coffee, a couple hours. It's not something that's too different for most of us in the rural area. So patients will, if they see a good program, they're going to drive for it. So that's what I was talking about from a creativity standpoint. We're going to have to, rural hospitals are going to continue to struggle financially. We're just going to have to be very innovative on how we're looking towards the future. Be it different services, oncology or bariatric or ortho or whatever, because just being here for primary, that in my world, it doesn't make sense.
Nick, from a doctor's perspective, what is the best thing we can do to attract doctors to rural areas and retain them out there? What needs to happen to keep that working?
I think that the thing that's the most effective is what Steve was talking about. It's having people from rural communities go to medical school and then come back. I mean, that hasn't worked everywhere, but boy, the places that have been successful have been able to successfully do that.
And are you seeing that? I know there's been some programs through the University of Iowa that have tried to do that.
Yeah, there have been. Yep. I think that we see a certain percentage of our medical school graduates who come to medical school. They plan to go back and work in the town where they grew up. And I think that that's wonderful. There have been a number of programs, loan repayment programs. There have been programs, related to immigration, right? Visa programs that have tried to facilitate capacity. You were referring before about the aging population, and that is 100% the case. That is in many rural hospitals what healthcare is, right? I think that Steve's probably a little bit unusual in that in his critical access hospital that they're doing OB, and most aren't doing a lot of pediatric care and specialty care. Many rural hospitals are really taking care of a geriatric population with a lot of kind of usual problems. I think that the policy levers here all have limited effects, right? The thing that, in my view, is the most effective is getting kids who grow up in a community to want to go back home.
Right. Because like the special visas have attracted a lot of doctors, but then once they fulfill their obligation, they often move somewhere else, which they're totally free to do, right? But that's what I've heard.
I think that's the truth of many of the policy levers, right? The thing that makes people want to stay in a community for their whole career is wanting to live in that community. And so a policy lever that takes somebody who doesn't want to live in a community and puts them in that community until their obligation is complete is maybe not as likely to have somebody want to live in that rural community for the rest of their career.
One of the things when I first came here, my docs would cover call in the hospital, and they'd also cover the ER. No extra expense or no extra reimbursement for it all, and they basically lived their life as a doc. Now we're finding that those kids coming out of medical school, want flexibility in their life, and they want to be able to enjoy life as well, and look at their priorities as their family, et cetera, not just their job. And so that's been not a struggle, but it's been a lot different over the years as people are coming out. They just want to live a different life than what they saw the older docs demonstrating in their small community.
Do you think that that's a major reason for the OB units closing, that nobody wants to be the only OB in a town and be on call all the time?
Yeah, I think so. And availability of C-section coverage.
Right.
That's always been a big deal.
Do you think that situation is going to stabilize? That we've had a whole bunch of birthing centers close in Iowa in the last 20 years or so. Is that going to continue, or where are we at with that, do you think?
There's a lot of small hospitals that are not doing a lot of babies, and I don't know, from a quality standpoint, I mean, I don't know how many babies you should deliver from, and feel comfortable about that. The number keeps changing.
Mm-hmm.
So I do see that it's not going to be financially viable for some of these rural hospitals to continue their OB.
Steve, just a question for you. To what extent does critical access hospital policy affect a hospital's decision whether they're going to have an OB center? Not at all.
Yeah. Not that I've seen.
Is it because obviously they're not Medicare case? Like, critical access, the main benefit is you get more Medicare money, right? And obviously, if a birth was a Medicare case,
yeah, we don't have Medicare OBs.
But is that the main reason is that part of the reason that a lot of these hospitals are closing OBs? Because they even if they have critical access hospital status, they don't get extra. That doesn't really help you keep an OB unit open, right? Or does it?
I think it's just availability of either family practice docs who want to do OB, or lack of OBGYNs in the community.
And can a family practice doc get trained to do a C-section?
Yeah.
Oh, okay. I didn't know if you needed a surgeon to do that.
Well, yeah. I mean, I've had a couple who went on for a year fellowship to be able to do C-sections.
And how many babies are getting born at your hospitals?
This year, I think we're looking at about 650.
Oh, wow.
That's gone up. When I started, we were at 70, and then 70 every year for like the last 40 years, and then all of a sudden just whoop. But a lot of the hospitals around me in 25 to 35 miles have closed their OB units, so we got those babies.
Wow. So you've been able to get the staff, obviously.
Yeah. The medical staff has been fairly stable. I have 4 to 5 FPOBs, and then 3 OBGYNs, and lots of advanced practice practitioners. And so staffing and nurses yeah, we haven't had an issue as far as staffing.
Well, that's good to hear. Well, we're getting fairly close to finishing up. I wanted to kind of wrap up with your thoughts on how optimistic people should be that healthcare is there. If you live in a rural area in Iowa or elsewhere, that you're going to have access to good healthcare and aren't going to have to move somewhere closer to a big city as you get older. How are you feeling going forward, Steve?
Uh, Kind of a Pollyanna optimist on it. Again, I think it's about creativity and really looking to the future. And I think with the bringing on the telemedicine, with looking at radiology and lab services and all sorts of wearables, etc. I think we'll be fine. I think we just have to be creative in how we approach the future.
And do you feel like the government that the funding is going to be there, both from the government and from private insurers, are going to continue to be supportive?
From government perspective, yeah, I think they're not. I don't think they're going to make any changes to the critical access program, and I think Medicaid will be good. Private insurance companies, I don't know. That's we're always seeing less reimbursement from the big insurance companies, so that's always a question mark.
And do you feel like I meant to ask you about the managed care organizations in Iowa's Medicaid program. When that first started, there were a lot of complaints about low payments and also just hard to get any payments. Has that situation gotten any better?
Yeah. We have three managed Medicaid companies in Iowa right now, and that's changed a lot over the years. But a lot of I think they continue to get better, and they continue to want to work with the local providers and the local hospitals. We're seeing more of them come out and work with us as opposed to against us. So hopefully we're going in the right direction.
Okay, I'm glad to hear it because, man, there was a lot of chaos and angst when it first started. Nick, how optimistic are you about that there's going to be quality healthcare for people who live in rural America going forward? And
Yeah, I think it's a good question. People do make decisions for where they live based on where they can get healthcare. There's a lot of variability in rural healthcare. Steve's talking about all the services that he can provide in his community. I think that one of the things that's unique about Iowa is that we've had a hospital in almost every county in Iowa for as long as we've had healthcare in Iowa. And the other thing that's unique is that many of those hospitals historically had been supported by the county in some capacity, or at least had been supported by the community. So I think that one of the things that's important about thinking about rural healthcare is that healthcare is a business, right? But it also, in many of these rural communities, is a function of the community. It's the way that the community cares for the people who live there. And the communities that do well with that are going to retain the citizens who need healthcare, and the communities that struggle with that are going to see people who leave because they need to be near high quality healthcare. People are astute. We've done a number of studies asking people what's important to them in their healthcare, and what people say is that as they age, they want to be near a place where they are confident that they can get high quality healthcare, and people can tell. And so I think that this will continue to be just like all of the other things that make a town a desirable place to live. This is something that many communities will continue to put effort and focus into. And I think that a lot of the innovation that we see in many rural hospitals in Iowa is really refreshing, because it is people who live in a community who want to take care of their friends and neighbors.
It's a really interesting point. There are only a couple of for-profit hospitals in the whole state, right? Which is unusual. How much do you think that helps, Steve?
Do we have any for-profit in the state?
Ottumwa.
Did they go back? Are they for-profit now?
I thought they were. I might have missed if they went back. And now it looks like Mercy, Iowa is going to be Mercy, Iowa City.
Oh, that's for-profit. Yeah. Yeah, it's really interesting. I started my career in for-profit hospitals out in New Hampshire back in 1990, and there's just for me, there was such a different perspective on how we looked at the patients and the stockholders and maximizing the profit. It was different. So, what was your question?
Oh, how much does that affect Iowa's health system? I mean, a lot of states have a lot of hospitals, and for whatever reason, that hasn't happened here.
Besides those two hospitals, I don't think we're going to really see a lot of movement towards the for-profit.
How come?
Because there's not a lot of profit in hospitals right now. It's easier to do something else.
Interesting.
One of the things that you talked about before was, supposedly 22 out of 120 hospitals are in danger in Iowa, or 117 hospitals. We don't, and they talk about danger. And Nick, you brought it up as far as governmental subsidies, county tax, that's helping to keep these hospitals open. You take all of that out of there. If we have a 0.5% bottom line or a margin, we consider ourselves lucky, so, there's not a lot of money to be made in healthcare right now. So,
well, if you look at rural hospitals across the country, there've been 110 rural hospitals nationally that have closed in the last decade. Well over 200 since 2000. I think that some of the numbers that we see, maybe a third of rural hospitals nationally are at right. The Sheps Center in North Carolina has published on this for years and years, and there clearly are risks here in Iowa too. But I think that some of those things that you were talking about, Steve, have made the healthcare landscape in rural Iowa hospitals a little bit more resilient maybe than they have been in other places. None of us know what that means for the next decade, though.
Right. Well, you guys, I think we're going to wrap it up. I appreciate your time so much and your insights. I very much hope that your optimism holds true. I'd like to see it. So thanks everybody for coming. I appreciate it.
Thanks.
Thanks, everyone.